As we begin on the back region, let us talk about the curvatures which are seen in the spine or the vertebral column. We need to understand that when a baby is in the intrauterine life, that time it is going to have what is called as universal attitude of flexion. Flexion means folding. So all the joints are folded in the intrauterine life. As you can see, the neck is in flexion, the upper limb joints are in flexion, lower limb joints are flexion, and even the vertebral column is in flexion. And there is a dorsal convexity. That dorsal convexity normally is called as kyphosis. So baby already has one kyphosis or dorsal convexity in the spine or the vertebral column. Now, as the baby is born, the baby is 2 months old, trying to hold the neck. That time there will be a change in the cervical curvature in the cervical region. The vertebral column is now acquiring one change, and that change is called as lordosis, because now there is anterior convexity coming. So this is second degree curvature, or this is the acquired curvature after birth, and we are calling it as cervical lordosis. Lordosis means now we are getting one anterior convexity in the cervical region, second degree curvature. And then we see during development, when the baby is 8 to 10 month old, trying to stand and walk, that time there will be another curvature changing, and that will be the lumbar curvature. So what happens in the lumbar curvature is that it again develops one anterior convexity, that is called as the acquired curvature, or again it is the lordosis, meaning that there is one anterior convexity in the vertebral column. Then what about the thoracic region and the sacral region? They remain as they were in the fetal stage. We understand in the fetal scenario, there was dorsal convexity, that is the kyphosis, and that kyphosis will stay in the thoracic region and in the sacral region. So when we look at the thoracic region and the sacral region, they have not changed. They have actually maintained their dorsal convexity or the primary curvature. This is 1 degree or primary curvature. This is 1 degree or primary curvature, which is basically kyphosis. So we have kyphosis or the dorsal convexity at two places. That is the thoracic and sacral region, and they are primary curvatures. So we have got two primary curvatures and we have got two secondary curvatures, which are actually acquired curvatures. Now, if a lady becomes pregnant, then there is a baby coming to the anterior side and shifting the center of gravity anteriorly. And that is why this lady will develop exaggerated lumbar lordosis. That is what happens during pregnancy. Continuing further in the back region and talking about the vertebra, we understand the human body has 33 vertebra in total. As we count, we'll having 7 cervical vertebra, and in the thorax region, we have the 12 thoracic vertebra. In the abdomen region, lumbar vertebra, they are 5 in number. As we come to the sacral region, 5 vertebra, they have fused to become one sacrum, and then 4 coccygeal vertebra, they have fused to become one coccyx. So as you count them, it comes to total 33 in number. Now, as we talk about the movements, we have discussed about the flexion or folding on the spine. A question comes, where do you have more of flexion, in the upper thoracic or lower thoracic region? You should answer that it is the lower thoracic region which is going to have more of flexion. So we are having more of flexion possible in the lower thoracic region, not the upper. Plus there is another question asking, rotation of the vertebral column is restricted in, and you should say it is restricted in the lumbar region. In the lumbar region, we find that the rotation is restricted because there is strong interlocking of the superior and inferior articular facets. They do not provide room for rotatory movement in the lumbar region. So lumbar region, less of rotation possible. These are some of the MCQs which they have asked. Then we will learn that there are some similarities in the cervical and the lumbar vertebra, which is different from the thoracic vertebra. So the features of thoracic vertebra are different as compared with the cervical lumbar. So what are the similarities between cervical and lumbar vertebra? For that we have taken this diagram here. We are mentioning there are some similarities in the cervical and lumbar vertebra which are different from the thoracic vertebra. vertebra. Now, before we start talking about the difference, let us talk about the similarities. Similarities are the body in the cervical vertebra is oval. So this is the body which is oval in the cervical region or maybe in the lumbar region, the body of the vertebra. Whereas when you look at the vertebral canal through which the spinal cord is passing, that vertebral canal is triangular. So vertebral canal in the cervical region triangular and vertebral canal in the lumbar region is also triangular. The sign of triangle is given. Now you reverse this and you'll find that is holding true in the thoracic region. So in the thoracic region, you are reversing the order and you find that the vertebral canal has become oval through which the spinal cord is passing. That vertebral canal is oval, whereas the shape of the thoracic vertebra is heart shape or triangular. So as you can see, it is reverse order. What we have just noted is there is similarity between cervical and lumbar vertebra in the sense that their bodies are oval. But then if you see the thoracic region, body is triangular or heart shape. On the other hand, if you look at the vertebral canal, maybe it is cervical region, it is triangular, or lumbar region, it is triangular, but in the thoracic region, it has become oval. So body is triangular and the vertebral canal is oval, which is exactly the opposite as we have witnessed in the cervical or lumbar region. Exact reverse order in the thoracic region. And it becomes evident if you take a transverse section of the spinal cord when it was passing through the thoracic vertebra region, you'll find that the spinal cord will be appearing oval. On the other hand, if you take the transverse section of spinal cord in the cervical region, the spinal cord will be appearing triangular, maybe in the cervical region or may it be the lumbar region. The transverse section of spinal cord while passing through the vertebral canal will be triangular in the cervical and lumbar region as compared with thoracic where it will be oval spinal cord. Now there are some characteristic features to identify the vertebra in the cervical region or thoracic region. In the cervical vertebra, we have got foramen transversarium for the passage of the vertebral artery which contributes to circle of Willis in the brain. So in the cervical region, there is one typical feature which is called foramen transversarium, and this foramen transversarium which is present in the transverse process, hence the name foramen transversarium, it let pass the vertebral artery, and vertebral artery passing through foramen transversarium is present only in the cervical region. You don't see any foramen transversarium in the lumbar region or in the thoracic region. So if you find foramen transversarium, you are sure that it is a cervical vertebra. Similarly, when you talk about the thoracic vertebra, there are ribs in the thorax region, and ribs will have articular facet on the thoracic vertebra. Then obviously, we do not have articular facet for the ribs in the neck region or abdomen region because we do not have ribs in the neck region or abdomen region. The rib facet will be seen only in the thoracic vertebra. So as you see, it is only the thoracic vertebra where you have the rib coming and making rib facet. So this rib facet where you have the plain synovial joints, these joints which we have with the rib and the vertebra, that is the costo-transverse or costo-vertebral joints, they are plain synovial joint. They'll be seen only in the thoracic region because ribs are seen only in the thoracic region. You do not have rib facet in the neck region or in the abdomen region. Now for cervical vertebra, we identify by foramen transversarium. For thoracic vertebra, we identify by looking at the rib facet. What about the lumbar vertebra? It becomes easier now. Lumbar vertebra is identified by the fact it has no foramen transversarium. It has no rib facet. So if rib facet is missing, foramen transversarium is missing, then of course it is going to be lumbar vertebra. Here is the transverse process which shows no foramen transversarium or rib facet. Then you look at one more feature here. The cervical vertebra have small body. The thoracic vertebra has large body. And lumbar vertebra has largest body. So the largest size of the body is present in the lumbar vertebra, whereas the smallest size of the body is present in the cervical vertebra. So small body, big body, and bigger body. Now when you say the cervical vertebra have small body, look at the C1 vertebra, atlas vertebra. It has no body at all. The body is missing altogether. So if we look at cervical vertebra, that is the C1 vertebra, the atlas vertebra will find it is having no body at all. Instead, it has large lateral masses. So these are the large lateral masses of the C1 vertebra or the atlas vertebra. It has no body at all. Now, as we were talking about the vertebral artery passing the foramen transversarium, this is the transverse process in which it has foramen. The transverse process in which it has foramen. And through that foramen passes the vertebral artery. Vertebral artery will come upward from the foramen transversarium of C1 and then it is arching over the posterior aspect of the vertebra. So this comes as a question. This is the third part of vertebral artery. So vertebral artery, the third part, is coming out of the foramen transversarium of the C1 vertebra and making a groove on the posterior arch of the atlas vertebra. It passes superior to the posterior arch of the atlas vertebra before it becomes part number 4 and enters the cranial cavity. This is the third part of the vertebral artery related to the posterior arch of the atlas vertebra. And also remember, vertebral artery passes through foramen transversarium of the upper 6 cervical vertebra. C7 cervical vertebra has a foramen, but there is no vertebral artery passing through that foramen transversarium. Moving further, we will find that we have a description of superior articular facets also. So these superior articular facets, they are directed backward and upward in the cervical region. But if you compare them with the thoracic region, in the thoracic region, the superior articular facet, not only they are directed backward and upward, but they are also directed lateral. You can remember T-bull. In the thoracic region, the superior articular facet is directed backward, upward and lateral. Superior articular facet means one vertebra is articulating with the next higher vertebra and they'll have some articular facet. So superior articular facet of thoracic region, it is directed backward, upward and lateral. Whereas if we were talking about the cervical vertebra, it was just directed backward and upward. It is no lateral or medial, just backward and upward. On the other hand, if you look at the superior articular facet of the lumbar vertebra, it is directed medial. So superior articular facet is directed medial. It is in the lumbar region. If it is directed lateral, it is the thoracic region. In thoracic region, it is backward, upward, lateral. Whereas in the cervical region, superior articular facet is just directed backward and upward. The type of joints which we find between the vertebra we can discuss here will be of 3 variety, and as we look at the midline intervertebral joint, that is actually the secondary cartilaginous joint or symphysis. One vertebra articulating with the next vertebra with the help of intervertebral disc, which is made up of fibrocartilage, and such a joint is called as symphysis. So midline intervertebral joints are symphysis or secondary cartilaginous joint. Other than that, these vertebra, they will have the superior articular facet and inferior articular facets. These articular facets, when they are making joints, they are plain synovial joint. So between the vertebra, we have number 1, the symphysis joint, and number 2, we are having the plain synovial joints, and number 3, we can say they are also having syndesmosis. Syndesmosis means fibrous joint. Now talking more about the fibrous joint, syndesmosis, here one bone is getting connected to other bone with the help of some fibrous tissue or the ligaments. So what are the ligaments which are connecting the vertebra with each other? We see there is one ligament which keep running anteriorly on the body of all the vertebra, hence named as anterior longitudinal ligament. So we can see the anterior longitudinal ligament here attaching to the anterior aspect of the vertebral body, the intervertebral disc also, and accordingly we'll find there is one ligament which is running posterior to the body, and if it is running posterior to the body, we can call it as posterior longitudinal ligament. So here we have got the posterior longitudinal ligament. So in front of the vertebral bodies we have anterior longitudinal ligament, and running exactly parallel to that behind the body of the vertebra we will have posterior longitudinal ligament. Along with that, now we will see there is one ligament which is connecting the lamina of one vertebra with the other. So this ligament which is connecting the lamina of the upper and lower vertebra, this is called as the ligamentum flavum, and this ligamentum flavum is having 80% elastic fibers and 20% collagen fibers. So this is the ligamentum flavum which is connecting the lamina of the adjacent vertebra, making the component of syndesmosis in the intervertebral joint. There are some more ligaments like you will see. This is the spine of the vertebra, and lying on the tip of spine of the vertebra connecting the two is called as supraspinous ligament. So here we have got the supraspinous ligament. That will be the posterior-most ligament, as you can see. Connecting the spine of the vertebra, we will have the supraspinous ligament, the posterior-most. Anterior-most was anterior longitudinal ligament. So anterior-most was anterior longitudinal ligament, and posterior-most is the supraspinous ligament. But then we have one interspinous ligament also. Let us look at the interspinous ligament as well. So between the spines of the vertebra, we have got interspinous ligament as well. So this is the interspinous ligament and can be tracked downward as well. We need to know about this because now we are doing what is called as the lumbar puncture. We have this lumbar puncture needle and we are doing the lumbar puncture. So what all ligaments are we going to puncture? First of all, we should say the needle is going to puncture the skin, and deep to the skin will have the superficial fascia, and deep to that will have the supraspinous ligament. So skin, social fascia, supraspinous ligament, and after that we'll have to puncture interspinous ligament. So skin, superficial fascia, the supraspinous, interspinous ligament, and then the ligamentum flavum. As you are pushing the needle, there was resistance to your movement, and suddenly there will be a loss of resistance. That sudden loss of resistance is felt as pop sensation. So you get a pop sensation, sudden loss of resistance as you puncture the ligamentum flavum to enter epidural space. Now you can give epidural anesthesia. But if you want to aspirate the CSF, then you'll have to puncture some meninges as well. And talking about those meninges, in this space was running the spinal cord. And as we talk about the spinal cord, this spinal cord is adherently covered by pia mater. Over that will have the arachnoid mater, and still outside will be the dura mater. So this is the spinal cord which was running in the vertebral canal here between the pedicles, and it was giving some spinal nerves also in the intervertebral foramen. So through the intervertebral foramen, some spinal nerves keep coming at regular interval. We have not shown the spinal cord here to maintain clarity of diagram, but it will be passing here. Now this needle, it has punctured only ligaments and it was in the epidural space. If you still move further deeper, you will have to puncture the dura mater and arachnoid mater so as to reach a space which is under the arachnoid mater, that is a subarachnoid space. And now you can do CSF aspiration or you can give spinal anesthesia. So which two meninges we have to puncture? We have to puncture the dura mater and also the arachnoid mater, and then we'll enter what is called as the lumbar cistern. This is the lumbar cistern where you do the lumbar puncture. It will be filled with CSF, cerebrospinal fluid. So to remove the CSF, what all structures the needle pierces? Number 1, skin. Number 2, social fascia. Number 3, supraspinous ligament. Number 4, interspinous ligament. Number 5, ligamentum flavum. Number 6, the dura mater. Number 7, the arachnoid mater. And then you enter the subarachnoid space, the lumbar cistern. You aspirate the CSF. You can inject the anesthesia agent also. Here we are going to talk about the yes movement and also the no movement. The yes movement is happening at a higher joint, which is atlanto-occipital joint, whereas the no movement is happening at a lower joint, which is C1, C2 vertebra or the atlanto-axial vertebra. So when we are talking about the flexion and extension, that is the yes movement or what is called as the nodding movement. What is the articular joint we are talking about? It is a joint between skull and the vertebra. In the skull, we have got the occipital bone, the occipital condyles, and below that we have got the atlas vertebra. So this is the atlanto-occipital joint. Now this atlanto-occipital joint is a synovial joint and it is ellipsoid synovial joint. Some authors may say it is condylar, but ellipsoid is a better answer than condylar. It is ellipsoid synovial joint. If not found in the option, you can say it is condylar synovial joint, and it is working for flexion extension. It is a joint between skull and the vertebra, atlanto-occipital joint. Nodding movement. But then as you go for the rotatory movement, which is the no movement, this no movement or the rotatory movement is happening at what is called as pivot synovial joint. The other name of pivot is trochoid. So you can say it is trochoid synovial joint or pivot synovial joint. It is a rotatory joint. It is between the vertebra C1, that is the atlas vertebra, and C2 vertebra, which is the axis vertebra. So this is the axis and that is the atlas. We understand that axis vertebra, C2 vertebra, has one projection upward, which is called as the dents of the axis or the odontoid process of the axis. So this odontoid process or the dents of the axis is articulating with the atlas. This is the atlanto-occipital joint, and on that it is the atlas which is moving. But as the atlas is moving, the skull is also moving. So atlas moving on the axis or rotating on the axis is the one which creates this no movement. And this atlanto-axial joint is a pivot synovial joint, also called trochoid synovial joint. It is for no movement and it is a rotatory type of movement. In this diagram, we are talking about the termination of the spinal cord while there is the fetal stage and then the baby at birth and the adult situation, along with the meninges and the spaces it will be related to. So here, as we look at the spinal cord in early fetal stage, that is 9-week fetus, we find that the length of the spinal cord is same as the length of the vertebral column. So this is the spinal cord covered by the meninges getting fused to the coccyx bone here in the vertebral column. This is the vertebral column. So this is the vertebral column inside which we have the spinal cord, and in the beginning, in the early fetal stage, the length of spinal cord and the vertebral column is same. In fact, the spinal cord tip is fused with the coccyx bone. But later, there is a differential growth between the spinal cord and vertebral column. Vertebral column grows longer. It becomes about 60 centimeter, whereas spinal cord remains only 45 centimeter. So as the vertebral column was becoming longer, the coccyx bone was going away from the spinal cord. So as the coccyx bone goes away from the spinal cord is actually appearing at a higher level. So this is early fetal stage. Then you see there is some distance appearing between the tip of spinal cord and the coccyx, and now the spinal cord is quite higher as compared with coccyx, and in the adult it is quite at a high level. So spinal cord, as you see here, is terminating at quite a high level as compared with the coccyx. But then we see there is one original attachment which is persisting. This initial attachment of the tip of spinal cord with the coccyx is persisting as some collagen fibers, and those collagenous fibers, they make what is called as the filum terminale. So this filum terminale is still attaching the coccyx bone with the tip of the spinal cord. So where is the spinal cord terminating? In a baby at birth. When you see the baby at birth, the spinal cord is actually terminating at the upper border of the L3 vertebra. Some authors will say lower border of L3 vertebra. First answer, upper border of L3 vertebra. If not found, change it to lower border of L3 vertebra. That is where the spinal cord is terminating in a baby at birth. And within 2 years of age, this spinal cord will reach the adult level. The adult level of spinal cord is lower border of L1 vertebra, which is also called as transpyloric plane. So transpyloric plane or lower border of L1 vertebra is the place where we have the pylorus of stomach becoming the first part of duodenum. That vertebra level posteriorly is L1 lower border, and it is also termination of adult spinal cord. Now spinal cord is covered by the pia mater. That pia mater does not stop here. The pia mater, which was covering the spinal cord, continues down, covering the collagen fibers and then reaching the coccyx bone. So the point is, maybe the spinal cord is terminating at L1 vertebra lower border, but not the covering pia mater. Pia mater continues down, covers the filum terminale, and pia mater finally reaches the coccyx bone. Then what about the next meninges, which is arachnoid mater? You will see the arachnoid mater now is outside the pia mater and is stopping at S2 vertebra lower border. So this is S2 vertebra lower border, termination of arachnoid mater. And not only arachnoid mater is stopping here, but also the subarachnoid space, which is filled with CSF. So deep to the arachnoid mater, we have the subarachnoid space, which is filled with CSF. That subarachnoid space is also stopping at S2 vertebra lower border. So arachnoid sheath and subarachnoid space stop at S2 vertebra lower border. And that is where we have the lumbar cistern. In the lumbar cistern, you can do lumbar puncture at L3, L4 vertebra to aspirate the CSF or give anesthesia agent, or you can also do at L4, 5 vertebra level. This is lumbar puncture we are talking about. We have to puncture the arachnoid mater to reach the lumbar cistern and then aspirate the CSF, inject the anesthesia agent. Here we are going to talk about the two enlargements in the spinal cord. One is in the cervical region, cervical enlargement contributing to the brachial plexus, whereas there is one lumbosacral enlargement in the lower part giving contribution to the lumbosacral plexus, say for example for the lower limb. So as we say, this is the spinal cord we are talking about, and in the spinal cord we are having one cervical enlargement and one lumbosacral enlargement. The cervical enlargement is having the spinal segments C3 to T2, and that is where we'll be getting the brachial plexus. The neuron bodies of the brachial plexus will be sitting here, and as we understand, brachial plexus will have 5 root values. For example, giving the radial nerve having 5 root values of brachial plexus must lie within this range, which is brachial plexus having 5 root values starting with C5, then 6, 7, 8, and it will also have T1 root value. So 5 root values of the brachial plexus, or you can say the radial nerve, is having the neuron bodies which are sitting in the cervical enlargement of the spinal cord. Then talking about the lumbosacral enlargement. Lumbosacral enlargement supplies the lower limb. For example, sciatic nerve. So what are the 5 root values of sciatic nerve, or what is the root value of lumbosacral enlargement? Remember the different values because they keep coming as questions. The lumbosacral enlargement as such will have root value L1 to S3, and within that range will come the sciatic nerve. Sciatic nerve also has 5 root values. So what are the 5 root values of sciatic nerve? Must be lying within this range L1, S3, and it is L4, 5, then S1, 2, 3. That is the root value of sciatic nerve which is supplying the lower limb. You must remember the root value of the lumbosacral enlargement individually and also the root value of sciatic nerve individually. All of these are MCQs. Another MCQ comes. This lumbosacral enlargement is protected by the last 4 thoracic vertebra. So which thoracic vertebra? And you answer last 4 thoracic vertebra are T9 to T12 vertebra. They will be protecting this lumbosacral enlargement. Now we know that the spinal cord is ending where we have this conus medullaris, and that will be the lower border of L1 vertebra. But then what about the meninges? What about the filum terminale? Filum terminale is made up of collagen fibers attaching to the tip of the spinal cord and reaching the bone coccyx down there. And it is having 2 parts. So what are the 2 parts of the filum terminale? There is one pial part and there is one dural part. And this pial part of the filum terminale is actually stopping at the S2 vertebra lower border. It is the same place where we have the termination of subarachnoid space also. So lower border of S2 vertebra, this much of the filum terminale is the pial part, whereas below the S2 vertebra till the coccyx level, it is the dural part of the filum terminale. We need to understand that the filum terminale is made up of collagen fibers and it is adherently covered by pia mater. So pia mater will be reaching till the coccyx level. Plus, when we talk about the arachnoid mater, it was stopping at the level of S2 vertebra, lower border. Then what about the dura mater? Actually, dura mater will start from the foramen magnum and reaches till the coccyx level. So which meninges reach the coccyx level? The dura mater and also the pia mater, whereas arachnoid mater was stopping at the S2 vertebra lower border only. When we talk about the lumbar puncture, we have a surface marking which can be used. While doing the lumbar puncture or giving spinal anesthesia, you have to tell the patient to go into flexion attitude. The spine will be in flexion or the vertebral column will be in flexion. We are looking at the back region here. And then we go to the highest point of the iliac crest on the hip bone. That highest point on the iliac crest on the hip bone, we can put a line, and that line is called as the Taffier's line. And at this Taffier's line, we have the landmark for the lumbar puncture. Our needle is going between L4, L5 vertebra, the intervertebral disc between L4, 5. So between the spines of L4, 5, you can push your needle. And that is how we do lumbar puncture for spinal anesthesia. In these diagrams, we'll be talking about the slip disc, and you should understand that slip disc is more commonly happening in the lumbosacral region, almost 90% cases, and about 10% cases will be happening in the cervical region. So 10% cervical slip disc and 90% lumbosacral slip disc, whereas slip disc in the thoracic region is very rarely observed. Now, before we start talking about the slip disc, you should know that the spinal cord, as we see from the lateral view, this is the vertebral column we are showing, and passing in the vertebral canal will be the spinal cord, and the spinal cord is having some spinal segments, giving the spinal nerves. Say for example, this is the spinal segment number C1 giving the C1 spinal nerve. And as the nerve is passing from the spinal cord, it will be passing out through the intervertebral foramina. So C1 nerve is passing above the C1 vertebra. That is the rule. Each spinal nerve will be passing above the corresponding vertebra. In a magnified view, seen from the front view, as you talk about the C1 nerve or C2-3 or any cervical nerve, each spinal nerve is passing above the corresponding vertebra. Say for example, we are at the level of C5 vertebra. This is C6 vertebra. So which nerve will you find above the C6 vertebra? It is the C6 nerve. So that is the point here. All the spinal nerves, they are passing above the corresponding vertebra. We started here telling C1 spinal nerve will be passing above the C1 vertebra. So it will follow, and as you are following, you can see that above the C6 vertebra, we are having C6 spinal nerve. So as you go down, now we have C7 vertebra. Which nerve will be exiting above that? That will be the C7 nerve. But then there is a change now. You see, we have 7 cervical vertebra, but the spinal segments are 8. So what about the C8 spinal nerve? Now, since you do not have C8 vertebra, where is the C8 spinal nerve going to pass? There is a discrepancy in the number of vertebra and the spinal segments. Number of vertebra in the cervical region are 7, but the spinal segments are 8. So what will happen to 8? Where the C8 nerve will pass? And as you can see, the C8 nerve is now passing under the C7 vertebra. Normally, each spinal nerve passes above the corresponding vertebra. Above the C6 vertebra, we have C6 spinal nerve. Above the C7 vertebra, we have C7 spinal nerve. But then C8 spinal nerve is passing below. And now the rule changes. Each spinal nerve will be passing under the corresponding vertebra. For example, now this is the T1 vertebra, and the T1 spinal nerve is passing under the corresponding vertebra, T1 vertebra. And then it will continue down. So the rule is, in the cervical region, all the spinal nerves pass above the corresponding vertebra, whereas now starting at the junction of cervical thoracic region, each nerve is now passing under the respective vertebra. For example, this is the T1 spinal segment giving the T1 spinal nerve. It is passing under T1 vertebra. And the same you can see here in a magnified view. Each spinal nerve now passes under corresponding vertebra. T1 spinal nerve is under T1 vertebra, and then it will continue. You can see the same happening here. Say this is the L1 spinal segment giving L1 spinal nerve. This L1 spinal nerve will be passing under L1 vertebra. So this is the spinal cord giving the L1 nerve, and it is passing under the L1 vertebra. Similarly, if it is the S1 spinal nerve, it will be coming down and passing under the S1 vertebra. So S1 spinal nerve has to pass under the S1 vertebra. The same thing can be seen in a magnified view here. Each nerve is passing under the corresponding vertebra. So if it is L3 nerve, it will be passing under the L3 vertebra. Similarly, if it is L4 nerve, it will be passing under the L4 vertebra. L5 nerve under the L5 vertebra. S1 nerve under the S1 vertebra. So what is the use of knowing all this detail? As I have suggested, most of the slip discs, they will be happening in the lumbosacral region, in this region. About 90%. 10% will be happening in the cervical region. And in the thoracic region, it is very rare to see slip disc. Now the point is, this slip disc, which is posterolateral herniation of nucleus pulposus, it is going to compress some nerves, and there will be some sensory motor problems. By looking at these sensory motor problems, you can diagnose at which level there is cervical slip disc, so that you can do MRI or CT scan at that particular level. Just by looking at the sensory motor problems of the patient, you can actually tell which level there was a slip disc. So which nerves are getting involved if we have cervical slip disc between C5 and C6? As you can notice, if there is a slip disc which is posterolateral herniation of nucleus pulposus, then it is going to compress the C6 nerve. So between C5-6, you have C6 nerve. And if it is between C6-7, the posterolateral herniation of nucleus pulposus, then the C7 nerve will be involved. Now this is about the cervical slip disc. What about the lumbosacral slip disc? In lumbosacral slip disc, if there is a slip disc, posterolateral herniation of nucleus pulposus, you will notice that the nerve which was exiting at the level is not getting involved, but the next nerve is getting involved. Now, why this happens in the lumbosacral region? Because in the lumbosacral region, the nerve exiting at this level is much more lateral. It is not involved. The next nerve in sequence gets involved. Say, for example, if it is a posterolateral herniation of nucleus pulposus or the slip disc between L3, L4 vertebra, then which nerve gets involved? We might think that the nerve which was passing between the two L3 nerve should be involved, but it is not. The next nerve, that is L4 nerve, is getting involved. It is due to a simple fact that the nerve exiting at the level is much more lateral, so it escapes the injury. The next one gets involved. Similarly, what is the nerve involved if it is a slip disc between L4, L5 vertebra? So the nerve exiting at this level is L4, but it is not involved. The next one, which is L5, will be involved. Similarly, if there is herniation of nucleus pulposus, slip disc between L5S1, which nerve is involved? Now, maybe the nerve exiting at this level is L5, but it is much more lateral, not involved. The next nerve is involved. That is S1 nerve is involved. But how will I remember all this information? For that, I'll give you a trick. It is a table and which can be used quickly to reach your answer. But one more thing which you have to learn here is the spinal nerves which are exiting in the cervical region, they are short and straight, as compared with the spinal nerves which are coming at the lumbosacral region. They are long and oblique. But why? Why the lumbosacral nerves are long and oblique as compared with short and straight cervical nerves? Because in the cervical region, they were simply given out like that. But since the spinal cord has already terminated at L1 vertebra, but the nerves still have to go down and then come out in the lumbosacral region, the spinal nerves become long and oblique as compared with short and straight spinal nerves in the cervical region. Now, what about the trick? How will I know which nerve is involved when there is a slip disc at one particular level? So here is the table which can be used as a trick to reach your answer. The questions could be something like that. If there is herniated disc between some particular level, then which nerve will be compressed? And the trick is go to the higher vertebra and add +1. That nerve will be involved. So if it is C5, C6 slip disc, then the higher vertebra is C5. Add +1. The C6 nerve is involved. Similarly, if it is C6 and 7, go to the upper vertebra C6. Add +1. C7 nerve is involved. So upper vertebra +1 nerve is involved. C6 +1, C7 nerve is involved. Similarly, in the lumbosacral region, upper vertebra +1 nerve is involved. Upper vertebra is L3 and +1 L4 nerve is involved. Similarly here, the slip disc is between L4, 5. Go to the upper vertebra, +1 nerve is involved. That is L4 +1. L5 nerve is involved. Similarly, if it is a slip disc between L5, S1, go to the upper vertebra, +1 nerve is involved. So what is L5 +1? L6. But there is no L6 nerve. It means the next nerve. That means the S1 nerve will be involved. So it is a simple trick. Wherever you have slip disc, maybe cervical region or lumbosacral region, just go to the upper vertebra, add +1. That nerve will be involved. You can see that now here itself. There is a slip disc between C5 and C6. So which nerve is involved? Upper vertebra C5 +1, C6 nerve is involved. So what about C6, 7? Upper vertebra +1, C7 nerve is involved. So when there is a slip disc here between C6, 7, upper vertebra +1 nerve gets involved. What about C7 and T1? What is the upper vertebra? C7. What is C7 +1? C8. So slip disc between C7 and T1, upper vertebra C7 +1, C8 nerve gets involved. The same rule, that is upper vertebra +1 nerve involved, can be used here also. So what about the slip disc between L3 and L4 vertebra? Go to the upper vertebra, add +1 and that nerve will be involved. Means L4. Yes. But why L4 was involved and why not the L3 was involved? Because L3 is much more lateral. It is not getting involved when you have a slip disc between L3, L4 vertebra. So slip disc between L3, L4 vertebra do not involve the L3 nerve. It involves the next nerve, L4 nerve. Instead of remembering all that, you simply remember a simple trick. That is upper vertebra +1. That is L3 +1, L4 nerve will involve. So can I use this trick here? There was a slip disc between L4 and L5 vertebra. Are you telling L5 nerve will be involved? Yes, L5 nerve will be involved. This is the L5 nerve which has got involved if there was a slip disc between L4, L5 vertebra. So instead of remembering all the anatomy, you can simply remember wherever they have given you slip disc, go to the upper value, add +1 and that nerve gets involved. What about the trick between L5, S1? What is the upper vertebra here? L5. L5 +1, L6, but we do not have L6. It means the next nerve. So which is the next nerve? S1. So slip disc between L5, S1 is not actually involving the L5 nerve. It is much more lateral. It is involving the next nerve, that is the S1 root value. That gets compromised. Or simply just follow this table. It is telling you wherever the slip disc is, there are two vertebra level given. Go to the upper vertebra, +1. So C5 +1, C6. C6 +1, C7. L3 +1, L4 nerve involved. L4 +1, L5 nerve involved. L5 +1, L6 nerve involved. But there is no L6. Instead of telling L6, you should say S1 nerve is involved. Let us use this information now in clinical practice as well. Now this patient came to you and he was complaining that he is having some burning sensation in the middle finger. We understand that middle three fingers, they have the dermatome C7 root value. So sensory problem at C7 level. Then you were checking for the C7 myotome also, the triceps reflex. You are doing the triceps reflex and you found there was weakness of extension at the elbow. Triceps reflex is diminished. Now, think yourself. Use the trick. Where is the slip disc line? Using our trick, we can say, going reverse in our trick, if these are the two vertebra and the nerve involved is C7 nerve, then how will I come to know which vertebra is involved? Our trick was very simple. It is upper vertebra +1 nerve is involved. So if you know the nerve root involved, you can always go back and find which vertebral level there was slip disc. So it'll be C6 and C7 vertebra. Between the two you had a slip disc and that is why the nerve C7 was involved. Upper vertebra +1 nerve is involved. So then you will ask the radiologist to focus his MRI at C6, C7 vertebra because that is where he'll find there is a slip disc. And the same thing you can notice here now. The radiologist has informed you there is a herniated disc between C6 and C7 vertebra. That is why upper vertebra +1 C7 nerve is involved, which is involving the dermatome of the middle finger. There was some sensory disturbance in the C7 dermatome, the middle finger, and then you found there was a problem with the triceps, wrist extension is a problem, and the nerve involved is basically the radial nerve with C7 root value, triceps reflex compromised. The same formula we can use for a case which came for the lower limb. This patient came to you telling that he is having some burning sensation in the little toe and the lateral margin on the dorsum of the foot. Then you understand that it is S1 dermatome. You are suspecting some S1 root value involvement. That is why you were checking for the plantar reflex. You take a knee hammer and hit the Achilles tendon. Do the plantar reflex. So when you were doing the plantar reflex, you were expecting that there will be a plantar flexion, but there is a weakness of that. So plantar flexion is becoming weak. It is again the myotome S1. So you are suspecting that there is S1 myotome, S1 dermatome involved. Where could be the slip disc? Again, we are going to use our trick, but in a reverse technique. Say, for example, it was some slip disc between two vertebra. We don't know which numbers, but we do know that the nerve root involved is S1. So by knowing that, we can find out where is the slip disc, because our trick is upper vertebra +1 nerve is involved. So what do you think which is going to be the level here? Of course, it is going to be the L5 and S1 vertebra level because upper vertebra +1 nerve is involved. So L5 +1, L6. But there is no L6. Instead of that, you should say S1. So that is what you told the radiologist. Focus your MRI at L5, S1. There you'll find a slip disc. And not a miracle, the radiologist informed you the same detail. He is telling you there is a herniated disc between L5, S1. As you suspected, upper vertebra +1 nerve is involved and there was some dermatome involved, S1. So little toe was having some burning sensation and this tendon, the Achilles tendon, it is basically gastrocnemius plantaris soleus muscle which is working for plantar flexion is weakened and that is why plantar flexion was having problem. The ankle jerk is going down. Tibial nerve is involved and the root value specifically would be the S1 root value of tibial nerve. Here we need to remember some of the bony landmarks on the back region, and as you can see, the cervical region we have to remember. The most prominent spine of the vertebra, which is C7 spinous process, also called vertebra prominence. It is quite prominent in the back of the neck. Then we have to remember the T3 vertebra spinous process, because that is where we have the beginning of the spine of the scapula. So spine of scapula begins at the level of the T3 spinous process, and then inferior angle of the scapula is lying at the T7 vertebral level. So T7 spinous process, we have inferior angle of scapula. Then we can come to T12 vertebra level. At the T12 vertebra level spinous process, we have the 12th rib coming here, and between the 12th rib and the erector spinae muscle, especially the sacrospinalis part of the erector spinae. So sacrospinalis part of the erector spinae and between the 12th rib, we have one angle, and that angle is called as the renal angle. The dermatome is T12 dermatome, that is the root value of kidney. So renal colic begins here in the renal angle, which is the angle between 12th rib and sacrospinalis part of the erector spinae. Then we have talked about the Taffier's line, highest point of the iliac crest and the spinous process between L4 and L5 vertebra. We can take the lumbar puncture needle and go here between L4 L5 vertebra for aspirating CSF or giving the lumbar anesthesia. So highest point of iliac crest, the Taffier's line. And then we have got the S2 vertebra, the spinous process of S2 vertebra. That is where we have got the posterior superior iliac spine on the hip bone. So when you connect the two posterior superior iliac spine on the hip bone, that will be a line at the level of S2 vertebra spinous process. And one more thing now you have to remember is tip of the coccyx is lying at the level of ischial spine in the hip bone when you talk about the anatomical position. So the ischial spine in the hip bone lies at the level of the tip of the coccyx in anatomical position. In these diagrams, we are going to talk about the two triangles in the back region, one upper and one lower. Upper is the triangle of auscultation and lower is the lumbar Petit's triangle. Talking about the upper triangle, you can see the boundaries. What we have to do is look at medial border of the scapular bone, forming the boundary, and then this muscle, which is the triangular muscle, the trapezius muscle, and another one which is lower back muscle, that is the latissimus dorsi. So as we are talking about the boundaries, the latissimus dorsi here, the medial border of scapula there, and trapezius muscle up here. This is the triangle of auscultation, bounded by the trapezius muscle, medial border of scapula, and the latissimus dorsi. It is the triangle of auscultation. As you can notice again, this is the triangle of auscultation, bounded by the medial border of scapula, and then inferior border of the trapezius, and superior border of the latissimus dorsi. At the floor of the triangle of auscultation, there are very few muscles. One of them being the rhomboid major comes as a question. And this is the triangle of auscultation. You can take your stethoscope and put it here on the back to clearly listen for the sounds of swallowing. Deep to that is the cardiac end of the stomach, and the swallowing fluids can be auscultated clearly in this region because it is having very minimal bone or muscle tissue and is very much in contact with the thoracic region. So triangle of auscultation. Now, what about the lower lumbar triangle or triangle of Petit? Here, once again, we have to involve latissimus dorsi plus the highest point of iliac crest and one muscle of anterior-abdominal wall, which is called as the external oblique muscle. So there is external oblique muscle anteriorly, latissimus dorsi superiorly, and highest point of iliac crest inferiorly. This is the lumbar Petit's triangle. You can see the same here as well. The lumbar Petit's triangle is bounded by the highest point of the iliac crest, then the latissimus dorsi muscle, and external oblique muscle anteriorly. So this is the external oblique muscle anteriorly, that is the latissimus dorsi muscle, and here we have the highest point of iliac crest. That is what we are calling as lumbar's triangle or Petit's triangle in the lower back region here. And remember the muscle which will be at the floor, it is the internal oblique muscle. Internal oblique muscle is lying at the floor of the Petit's triangle.